Mormon Mental Health Podcast is a production of the Open Stories Foundation and relies on donations from its listeners like you. To help keep this podcast alive, please consider becoming a monthly subscriber. Any amount will make a difference. You can click the right-hand donate button on mormonmentalhealth.org. All contributions are tax-deductible within the United States and go towards podcast production and building community support and program development for Mormons on various paths and journeys. Thank you for listening. Hello, welcome, Mormon Mental Health. This is Natasha Helper Parker. I am here for an interview on a really interesting topic that I want to learn a lot more about. And so what better way to do that than to post it here on this podcast so that you can learn about it with me. I have Kevin Kloosterman, who is a dear friend and colleague who just recently went through some fairly significant training on a evidence-based practice called RO-DBT, and we're going to tell you all about that. And it's shown to have specific success with those dealing with either chronic kind of resistant-based depression, clinical depression, and or anorexia. So we're going to talk a little bit about that. Before I get started in the interview process, I just want to, again, give a quick shout out to all of the donors that participated in 2018 as far as making this a financially sustainable podcast. Thank you so much for your donations. I have to continually ask for that to continue to happen in 2019 to make it a sustainable podcast as well. So if you find value in these types of resources that I love providing, and it's just something I'm very passionate about and willing to do at very low cost, please consider a donation. And, if you can donate monthly as a subscriber, that would be amazing. It can be $5 a month, $1 a month. Of course, I'm not going to balk if you spend more than that a month, or it can be a one-time donation. So please consider that, because I cannot run this podcast show without some financial means to help the people, pay for the people who help me edit, pay for some of the backdrop that, all of these websites and platforms cost money, and also to, just give some level of fee for those who participate. So yeah, help me run this well and have it be super sustainable. If you're interested in any other things that I'm doing as far as my private practice, workshops, presentations, anything along those lines, please go to a totally different website, which is my private website, which is natashaparker.org. And that will give you all of the information about other things I'm involved with, because sometimes I get questions about that. All right, so before too long here, let's go ahead and get started. Kevin, thank you so much for joining me tonight. And let me just kind of hand it over and have you introduce yourself, because my main way of having known you was through the Mormon Mental Health Association. Although I will say the first time I ever heard you speak, this is totally a tangent, was at a Sunstone event in, I believe, Kirkland. Is that correct? Kirkland. And I did
Kirkland Temple, actually.
At the Kirkland Temple. And I didn't know you from Adam. And you were, you were a practicing bishop at the time, I believe, or maybe had just recently been released, somewhere along in that time frame where you had just been that, and you were getting quite a bit of attention because of your advocacy for LGBTQ plus members of our church, and kind of sharing some of your experiences of how that had really impacted you during kind of this term of being a bishop in your ward. So that was super interesting. I loved hearing you talk, and I made it, a goal of mine to get to know you better. Recruited you for the Mormon Mental Health Association, which you took up my invitation. So I loved that. And that's a whole nother resource that's out there for people to know about, which you can look at Mormon Mental Health, ASSOC.org. So I'll just give a little shout out to that. And you served on our board, and you've just been so helpful to me in so many ways over the years. So I'm finally getting to sit down and interview your brilliant mind. So Given all of that, now introduce yourself as far as just normally.
Oh boy, this is going to be a high bar here. Wow. No, you're a great friend, Natasha. I love just everything you've been involved with, and you're wonderful. So thanks for having me on your show. And so yeah, my name's Kevin Kloosterman. I'm a former bishop, but I'm also a licensed marriage and family therapist. I've been in the mental health field for almost 25 years, and I have a private practice. I've also worked in a hospital setting, also inpatient and then outpatient. So yeah, it was probably about 2 or 3 years ago that my healthcare system sent me on this, sort of training about this new type of therapy called RO-DBT. And at first I was like, okay, so this is just kind of a spin on, kind of regular old, standard DBT. And DBT is a type of therapy, and it stands for dialectical behavioral therapy. And usually it's a type of therapy that's used to treat individuals with something called borderline personality disorder, typically. But it's also been found to be helpful with certain other mental health challenges and disorders. So I wasn't really expecting too much. You go to these presentations and you maybe hear some interesting things here and there. And, so I go there, and the developer of the models there, and I was just like floored. I was like, wow, there are some things that I haven't really ever thought of before, ever heard of before. Some language and some concepts that I thought, wow, I'm really interested in this. So came to find out that RO-DBT has gone through clinical trials through the National Institute of Mental Health and is now designated as an evidence-based practice for chronic depression. Or depression that just does not seem to be responding very well to traditional treatments, including medication and just more kind of traditional types of therapy. And so the National Institute of Mental Health started to get how this all came about is they got some research and some feedback that a lot of people just are not responding as well as we would think or hope with depression. A lot of people are, but there's a lot of people where medication and therapy, it might be sort of arresting the symptoms and sort of creating a floor so things are not getting worse, but they're not really getting much better. And then there's some people that are just not even responding at all to medication and traditional therapies. And so that's how RO-DBT was developed. And also,
do you by chance have statistics on that? Like, I want to say somewhere in the 60 to 70% range has some success with medication. That number, and also talk therapy. And if you combine those two, you get a slightly even better result. But that still leaves like 20 to 30. I mean, I'm popping these out of my head. I don't have them right in front of me, but I think I'm fairly on the right track there.
Yeah, what they showed us was that with depression, about a third of the people are responding really well to medication and or counseling, traditional counseling. A third of the people, it's sort of arresting those symptoms, and it's not getting worse, but it's not getting much better.
I see.
And then there's a third of the people who are getting worse, basically, regardless of what, whether it's medication or kind of traditional therapy. So those were kind of the stats that they threw at us in our training, and I can send you the research article that they have.
Yeah, that'd be great. We can link to that for sure.
And so, yeah, obviously the National Institute of Mental Health was concerned. Mm-hmm. And that's
a lot of people. It's a lot of people, 20 to, 30% of people suffering from chronic clinical depression. That's a lot of people, because we know a lot of people suffer from depression to begin with.
Right, exactly. And also the National Institute of Mental Health, what they're kind of looking for is they're looking for therapy models that are, one of their priorities is to find therapies that are transdiagnostic. And what that means is that it's a type of therapy that different disorders or mental health challenges that may share some similarities, this type of therapy could be used, even though there may be different diagnoses. So RO-DBT not only is an evidence-based practice for chronic depression, but it's also an evidence-based practice now for anorexia.
Interesting. I wonder, did they talk anything about why that might be the case? Because anorexia is also known as a fairly, resistant type disorder to treatment. And what I mean by resistant type, it's not that people are resisting treatment, is that it's difficult to treat effectively, even when people really want effective treatment themselves.
It may be one of the most challenging disorders to treat, in my opinion. There may be a few others, but it definitely is very, very challenging to treat. So the fact that RO-DBT was able to get that designation is pretty significant. So I'll kind of share with you why those two diagnoses of depression and anorexia, what they may share. And as we talk about depression, we're going to be talking about not all depression is equal. There's sort of different types of depression. And, kind of what we're going to be talking about is this idea that, I guess in the past, what the paradigm is that the more self-control a person has, the better their mental health is going to be. And so a lot of therapies are geared to trying to help people to, kind of gain more control, get more self-control. And self-control is a really good thing. It's a really important thing. And you can imagine if, society or the world or people, just all of us completely lost any sort of shred of self-control, that probably wouldn't be a good thing. So self-control is really important, but what we sort of now find with this new research is that there's some people that may have too much of a good thing. They may actually have too much self-control. And that actually is starting to cause some problems with their mental health and then also with their relationships. And it's being manifest in their relationships. So they've come up with this term called overcontrol, that, there's some people that, kind of have too much of a good thing, too much self-control. And so,
does this at all, it makes me think of perfectionism, or you're talking about something different?
No, you're exactly on the right track there.
Okay.
So something like obsessive compulsive personality disorder, which is distinct from obsessive compulsive disorder. Obsessive compulsive personality disorder is really all about perfectionism. It's perfectionism in overdrive. And so RO-DBT would really fit that type of diagnosis, in addition to depression that's not responding well, treatment-resistant depression, treatment-resistant anxiety, and anorexia. And it has to do with this over-control. And there's part of what we see with people who have this over-control, and we call it maladaptive over-control, because all of us have some over-control characteristics. Where it becomes problematic is when people get stuck in over-control and they're not able to adapt to what the context of the situation is. And they keep adding more and more control when it's not necessary or it's not helpful for them.
And
So
not to throw a total wrench into your thought process, but then the next thing that comes into my mind is, could this potentially be a higher risk factor for those within a Mormon population? Because although I'm not sure there's hard data to show that Mormon culture or Mormon population is more perfectionistic or has more perfectionistic traits than the rest of the population, although maybe there is, and I'm not aware of it, but is it, at least in your experience, possibly something that might be of interest to those within either Mormon culture or treating those within Mormon culture?
absolutely. And that's going to be a really exciting part of what we talk about here is I think there's some aspects of LDS culture that that really align with this over control, like very rigid kind of rule governed behaviors. But some parts that are different from that too. And we'll kind of talk about that. So we can sometimes see these OC characteristics, over control characteristics, when kids are really young. And so, on the other side of the fence, we have kids who are, kind of more under controlled. They tend to be very emotionally expressive. They can be really loud, and they can be kind of attention seeking and really like the limelight, and maybe they're a little bit impulsive, and maybe they're a little bit of a chatterbox, when they're young or when they're older, and they kind of like being the center of attention, and maybe they break the rules a little bit, and maybe their teachers sort of tell them, hey, you got to kind of settle down a little bit. And then on the other hand, we have other kids that we can see pretty early on in preschool, or, certainly by school age, where they don't like to be the center of attention at all. And they really work hard to try to avoid it. And they just kind of keep their heads down, and they're really hard workers, and they don't like taking risks. They really don't want to put themselves out there. So we can start to see that biotemperament part pretty early on, and it kind of
You're talking about like 2 or 3 or kindergarten age, or
certainly by preschool or school age.
Mm-hmm.
And so we kind of call the kids that really like the limelight, we call them UC, or emotionally under controlled, and they're very expressive, and they like to have a good time, and they can dysregulate very quickly. One minute they're excited and they're on top of the world, and then the next minute they're crushed and they're sad, and they're crying, and there's a lot of emotional volatility with UC people, with UC kids, and then OC is much more much more reserved, much more serious, and, very hardworking, not impulsive, very kind of rule governed. And
are these just traits that fall under just normal differences between humans, or are you talking about using these labels in a way to kind of say something is a little bit kind of off the rails as far as how exaggerated these traits show up?
Yeah, so I think the way they would conceptualize this is, kind of for all humans, we sort of lean kind of one way or the other. We sort of have a dominant style. And that's not to say that we're never on the other side of the fence. In fact, most people have both, kind of sets of characteristics. But what we're looking for is which one is more dominant, kind of like, somebody who is right-handed or left-handed, they have a dominant hand. It doesn't mean that they don't use their other hand. It just means one is more dominant. So we're looking for that. And then the other thing we're looking into is it maladaptive? Does it get stuck? Does the person have a hard time turning off UC characteristics when it's time to be serious? When it's time to really put your shoulder to the wheel and get to work, and or does an OC kid just, or person or adult, really find it hard just to chill out? just to be able to relax, just to even be able to have fun, just to be able to connect with other human beings? Do they get stuck in that all the time? Are they wound too tight, and we have to use RO-DBT to kind of loosen that up a little bit and to teach them some things that don't come naturally to them? So standard DBT is really great for people who are on that UC side of the fence, who are too emotionally volatile and can't control their emotions, and they need to learn mindfulness, and they need to learn how to tighten up a little bit. And it doesn't come naturally to them. And RO-DBT is the opposite. It's really there to help those people who are so perfectionistic, they don't even know how to chill out and relax and take it easy. And, they're overworking themselves, and they're also, without even really knowing it, pushing people away from them. And we'll talk a little bit more about that maybe later. But
so I'm having a metaphor that pops into my head. You're just gonna have to bear with me, because I am a sex therapist. But it's kind of like I've heard so many positive things about DBT, and it almost feels like we can use DBT on almost everything. People who are depressed. Like you said, it started out with personality disorder, but then it went, it was treated for bipolar. There were some success rates with just depression, anxiety in general, et cetera. But
right.
like you're saying, DBT is mostly focused on emotional, kind of being able to manage your emotional well-being, kind of like hiring your emotional IQ. But some people are too good at that. So it reminds me of Kegel exercises. So like you'd think Kegel exercises are good for everybody.
I've never tried Kegel exercises.
They're good for men too, Kevin.
Are they?
Yes.
I'm getting some sex therapy here.
Urinary incontinence and bladder control and all kinds of things.
Maybe it's good for the prostate. Who knows?
Yes. But if you have vaginismus, or if you have a lot of anxiety where you kind of hold your core too tight to begin with, and you're having problems with penetration or anything like that, Kegel exercises are like the worst thing that you could be doing, because it kind of strengthens that thing that you're already way too good at, if that makes sense.
Yeah,
is my metaphor working for you?
I think that may be a good fit. So yeah.
So RO is non-Kegel emotional exercises. And can you say what RO stands for?
RO stands for radically open.
Radically open.
So with standard DBT for kind of some of the emotional volatility and impulsiveness, standard DBT is really good in teaching people how to have impulse control. Because really emotionally centered people, they can be impulsive. They can say and do things that are not always wise. And so part of what standard
gets in the way of relationships.
Absolutely. So that affects relationships where, there's a lot of drama and there's a lot of volatility in those relationships. So standard DBT comes up with this concept of radical acceptance, and just being able to learn to, kind of radically accept things as they are. What we kind of say with OC folks is they're already doing that maybe a little too much. And they may be sort of, kind of closed off to new experiences, novel situations. So we've sort of drilled down and kind of figured out what are the qualities of OC people who tend to have this maladaptive overcontrol. And what we find is that with OC people, they have very low reward sensitivity. What that means is they don't really get that excited about things. Like when I saw your face pop up on my phone, I was like, it's Natasha! I can't believe it! We haven't talked so long. I was just so happy to see you. I was just excited, okay? And so,
I felt the same way, by the way, Kevin.
This may betray which side of the fence we may lean to, right? We're on Facebook Live. Look at us, everybody. We're comfortable in the limelight, you know?
Right.
So, so reward sensitivity. So you see people, you know, they have kind of high reward sensitivity. They can get excited about things and really enthused about things pretty easily. And they can even get kind of dysregulated, where their emotions kind of get out of control almost, with the presence or the absence of kind of things that are rewarding. With OC people, it's really different. They part of their biotemperament is they don't really get that excited about things, you know?
And when you say biotemperament, you're talking about you're kind of born this way, like this is part of your biology?
Right.
Okay,
Right.
just to clarify.
Yeah, and then we'll talk about environment a little bit later. But, you know, for me as a, you know, who leans kind of UC, really UC, you know, somebody gives me a new pen, it's like, oh my gosh, I got a new pen. Look at this. It's incredible, you know. And, you know, somebody who's really maladaptive OC, you know, would be like, so I just won the Powerball. And, you know, I'm now, you know, a multimillionaire. So I'm really excited about that.
This sounds like Eeyore's diagnosis.
Yeah. Eeyore's
Yes.
OC, I think.
I love Eeyore, by the way.
Yeah. Who doesn't love Eeyore, you know? And because I have high reward sensitivity, when people talk about Winnie the Pooh, I get really excited.
Right.
Winnie the Pooh characters. So that's one thing that we kind of look for when we're kind of drilling down on this is what is the person's reward sensitivity? So that's one thing. Another thing is threat sensitivity. And for UC people, and it can kind of depend on their experiences, but there's quite a range. It could really be low reward, low threat sensitivity, or, you know, kind of medium or high. And what that means is, you know, you're kind of looking out at your environment and you're really kind of on your guard if you have high threat sensitivity. And you see people, it could be anywhere from low to medium to high. With OC people, over control, especially maladaptive over control, their biotemperament really from the get-go starts off with very high threat sensitivity. So they're looking at their environment as, you know, they're scanning for potential problems. The glass is half empty. Things could go badly. Mistakes could be made. You know, there's things that could hurt me. So yeah, OC people, they tend to have high threat sensitivity. So, you know, they're kind of in an anxious defensive arousal state a lot of the time, actually, which creates a lot of problems, as you can imagine. The third thing with biotemperament is detail-oriented processing. So UC people, we tend to be more kind of global processors, you know, kind of seeing big patterns, big picture, big ideas. And OC people, they are much more into the details. They are detail-oriented processors. So you might say that UC people, we kind of see the forest a little bit better, but we don't always see the individual tree. Whereas an OC person, they're really good at seeing an individual tree, but not always good at seeing the forest. One way of kind of thinking about this that I do when I'm, you know, trying to find out if somebody is more kind of UC or OC, I kind of say, okay, if somebody had a brain that was highly detail oriented, really, really able to focus on the details, and they had high threat sensitivity, meaning that they could see potential problems, potential danger, potential things that could hurt you. And let's say that person who has this type of brain with very detail-oriented, high threat sensitivity, they walk into a rose garden. What's the first thing they're going to see?
all the potential ways you can be harmed.
Exactly. They're probably going to see the thorns or
The bees.
bugs, the bees, the wasps, the little part of the fence that has, something jutting out that could, scratch them if they weren't careful. The last thing they're going to see is the roses. So you can kind of imagine a kid or a person kind of going through their life looking at things in that sort of way. And whereas a UC person would be like, oh my gosh, look at these beautiful roses. Oh my, they
The
wouldn't
smells
even, and then boom, a thing of bees could sting them all over the place.
Yeah.
A UC person's going to just jump in without even thinking about it. Whereas an OC person is going to be more kind of careful.
Yeah. So two things I want to say. One is just my own comment. So again, when we're talking about traits, we're not saying one is better than the other. I hope it's coming across that both have pros and cons, and that both can become maladaptive, right? So you can be maladaptive on this side and on this side. But tonight, since we're talking about RO-DBT, we're going to be talking mostly about how OC, can become maladaptive. Then we got a question, which may be unrelated, but if you have an answer, great. And if not, you can just say, I don't know. But Allie Payne, who's joining us, so hello, Allie, says, is OC UC related at all to the Myers-Briggs test?
Well, I don't think that there's been research on that, but this is my own kind of speculation, is that the characteristics that I'm describing, you can start to see how some of these things in the Myers-Briggs get generated. Kind of this introvert extrovert is one component of it, right?
Right.
So, if somebody has really high threat sensitivity and they're very detail oriented and they're able to see potential things that could be problematic, well, being extroverted is kind of taking a risk. You're really putting yourself out there if you're going to be in the limelight, and you're going to put yourself out there. So I don't know that it totally meshes completely, but these are things that we've been able to actually drill down on it, and there's research behind it. There's some really, really strong research, and I wouldn't be surprised if there was sort of this kind of Rosetta Stone to try to translate, both of these kind of,
how they interweave.
Yeah.
Well, a lot of these clinical tests and personality tests are taking into account, kind of traits of people, right? And so it's when certain theorists or researchers come up with certain types of traits, of human traits, and then you'll have other tests or other ways of looking at human behavior. And so there's usually an interweaving that can definitely be at least thought about or correlated, but whether or not, I think what you're saying is whether or not that's been backed up by research and there's a firm correlation that we're not sure of.
Right. And I'm a big fan of Myers-Briggs, and I'm an INFP. I really like well, I'm kind of on the I'm what they would call an ambivert. I'm right on the edge of introverted and extroverted, whatever that means. So but great question, and we heard that a lot in our training, and the developers sort of turned away from that a little bit and just said, this is a little bit different. We're going to be treating depression and anorexia and using these characteristics to really focus in on that. But it's a great question. It's been brought up a lot, and I've got more thoughts on it. But yeah.
Good. Allie says I'm an INFP.
Yay!
So, there you go. You got a fellow person listening. So and anybody feel free to, answer or ask questions along the way. So hopefully you'll take us up on that for those of you who are watching us live. So, okay. Well, I didn't mean to distract you from your kind of train of thought. So where do you want to go next?
Next is one last biotemperament category, and that's delayed gratification. And so you may and others may have heard of the marshmallow experiment. It's something that we've done with kids for a long time. Basically, the gist of it is that we have a kid in a room, and the person or the researcher says to the kid, "Hey, I'm going to give you a marshmallow, and I'm going to leave the room. And if you don't eat the marshmallow, by the time I get back, I'll give you another marshmallow. But you can eat it now if you want to. If you eat it now, you won't get a second one. But I'm going to leave the room. And if you are able to hold off on eating this marshmallow, when I get back, I'll give you another one. You'll have two." And so we can kind of see this biotemperament, again, by preschool age, and you can kind of tell that this is not something that these kids have necessarily learned. It's just kind of how they're wired. And if you look it up on YouTube, you can see it's kind of fun to watch. There's some kids, the UC kids, even before the researcher finishes their sentence, the kid's already eating the marshmallow. I got a marshmallow.
And they haven't shown these studies to be super traumatic to the point that we can't do them anymore on human subjects.
Right. And I just remember seeing this OC girl, and she's so stoic and so strong. And, she just kind of moves her plate out of her view. And she's little, she's probably only like 3 or 4. And you see that delayed gratification with her. And so, yeah, obviously OC people, they're going to be wired to be able to delay gratification, longer than a UC kid. So those are all kind of the biotemperament parts. And now we can kind of talk about family and culture.
Yes.
And also specific to, members of the LDS Church or those who grew up in a Mormon heritage. So obviously family and culture shapes us. And you can kind of think about families or your school system, or if you grew up in a faith community or a church, or just any culture that you're kind of born into, you can kind of see, some UC parts and some OC parts. And the thing that we get kind of concerned about is if you have a kid who is already kind of temperamentally OC, over-controlled, and you kind of put them in a family or a school situation or a church situation that is also highly over-controlled, then that kind of gets put on steroids. And that's where it can be pushed into kind of maladaptive, sort of territory. And the way we kind of look for that is kind of in 2 ways with 2 questions. So we ask somebody, were you ever given the message, either as a kid or, as a teenager in your family or at school or, in your culture, that showing emotions was a sign of weakness? That if you show your emotions, you're kind of a weak person. So they can kind of think about that. In general, is the culture that they were exposed to, whether it's in their family or wherever, did they get that message that showing emotions is really a sign of weakness? And the second thing we look into is, did you ever get the message that making a mistake is intolerable? And if those messages are really heavily promoted in their environment and they're already OC, then they're at risk of being in that sort of maladaptive category. Kind of over control on steroids, self-control on steroids. So obviously, I was kind of doing a lot of thinking in LDS culture, and, there's some parts that, kind of promote UC, and there's some parts that are much more over control, very rule governed kind of behaviors. So,
and so interesting. This is what I hope people really get from this, is that you can have certain aspects of our talks or our culture or messages that come across the pulpit and affect people very differently. And I think it's so important to building our empathy towards other members' experiences, right? So if we're having a really good experience within Mormonism and
right.
somebody's saying, I feel consistently shamed, or, you know, like I'm being treated like I need to keep all these rules. And another person's like, well, that's not my experience at all. Some of that, especially if you're in the same exact, you know, ward system, because some of those differences can just differ by different geographical settings. But if you're dealing with kind of the same people and having different experiences, that may be part of this equation, that one of you is more UC oriented versus the other's OC oriented.
Yeah. And you can kind of see it with, you know, some of the leaders, you know, whether they're kind of UC or OC. And, you know, you don't always know for sure. And I'm not, you know, I'm probably just kind of maybe speculating. I'm not interviewing them in a clinical context, but you see somebody like Henry B. Eyring, who consistently just has trouble controlling his emotions, right? He gets very, very tearful, almost right off the bat. And so you kind of think, okay, he's more on that kind of UC side of the fence. He can get dysregulated really easily. Jeffrey R. Holland, you know, probably another, you know, sort of good example of somebody who's probably more very charismatic, you know, you know, the emotions can go up and down. But you look at somebody like Elder Bednar, very, very stoic, you know, really has that kind of almost a flat neutral face. And so, you know, he's kind of that, may possibly lean more on that OC side of the fence. I was thinking about a book that you're probably aware of for children, that you and I, you know, probably weren't great fans of when we heard about it.
Can I say it before you even say it to take a guess?
Yeah, let's see if we're on the same.
The Not Even Once Club?
Not Even Once.
Oh, my Lanta. Yes. Why would we not be fans of that, Kevin?
Yeah. So you kind of give an OC kid who may be in an OC family a book that sends him or her the message, mistakes are intolerable. You should not ever make a mistake, not even once. Yeah, that could put OC on steroids and really push it into kind of maladaptive over control. So, but on the other hand, fast and testimony meeting, right? You know, it's usually, you know, tends to be a spontaneous experience. You know, now we know that there's people who kind of rehearse and plan, you know, what they're going to say. And sometimes I've seen people, you know, bring some notes up there, right?
Sure.
Fast and testimony. But you know, it tends to be a spontaneous experience. Again, that leans more towards kind of a UC component of our culture. And if you go way, way back in our history, you know, to the really kind of charismatic founding where people are speaking in tongues and all kinds of stuff, you know, that's very UC. You know, now our meetings are very, very regulated and very structured, and but
very
fast
OC.
and testimony, yeah, very OC, but fast and testimony is a little bit different. It's unstructured. We don't know who's gonna get up.
Yes, that's true. To a point, we tolerate a certain amount of unstructured to a point, and then the microphone gets turned off.
Yeah, right. Yeah, especially if you're you know, a gay teenager trying to come out to your ward.
Yes. Oh, yes.
But,
so sad.
Yeah, you know, and we also, you know, we sort of see people showing emotion at the pulpit. We don't always look at that necessarily as a bad thing.
Oh, no. Yeah.
You know,
I see it as a good thing. Yeah.
Yeah. In fact, some people would say, oh my gosh, they're feeling the spirit, you know? So, you know, on the surface, I think as I looked at it, I saw our culture as mostly OC, and maybe that's true. but there are some UC elements in it as well. And but like you said, just you can't emphasize it enough. Everybody is sort of having their own experience in Mormonism, and just because you may be having a wonderful, great experience doesn't mean that, somebody else is really being hurt. So, kind of speaking as somebody who grew up in, kind of patriarchy and, kind of men and the priesthood and things like that. For us, a lot of it is, duty, responsibility, it's not a time to, necessarily, especially when you're performing ordinances, you are not to be silly or goof off at the sacrament table when you're blessing it, or when you're passing the sacrament. It's a very somber, structured, serious thing, So, everybody's sort of having their own kind of experience. If you have a bishop who tends to be on the OC side, he may not be very open or flexible to new things, new ideas. On the other hand, if you have a UC bishop, let's try it out,
Right. Well, and even disciplinary factors go into this, where an OC bishop may keep a young man or stake president even may keep a young man or young woman from going on a mission for certain, kind of sins or transgressions, whereas a UC bishop may not. And this is, what we consider bishop's roulette, right? We kind of have that term where
bishop roulette.
Yes. Yep. Mm-hmm. Well, that's a wonderful overview of how, first of all, what are some of the things we're looking at as far as traits, and then some of the environmental factors that can so much play a role. You mentioned, kind of through the LDS framing, but it's like your family probably has a certain orientation, your community might have a certain orientation. Your ward or your church may have a certain orientation towards one of those things. And so as an individual,
or even your country,
country. Interesting.
You think about, Italian culture,
Yeah, I know a little bit about that.
Do you know about that?
Yes.
Yeah.
Yes. So, I think that's why I'm a little bit loud and extroverted.
Yeah. Just always serious all the time. Keep those emotions in, right? That's Italian culture.
That's how we are.
So that can play a role. And then, I went to Japan on my mission.
Yeah.
That's, when you're on the subway in Japan, you don't make a spectacle of yourself. Everyone's pretty rule governed,
Sure. Yeah.
Some cultures, it's a different culture, and kind of some of those OC characteristics may be valued a little bit more. And then, you got the United States where, arguably probably a little bit more of a UC culture. You go down, in New York City or, Venice Beach or, some other places. And you see some really interesting things, right?
Yeah. Well, and even within the country, because I'm telling you, Wichita, Kansas is not like New York City.
Absolutely. Yeah. I mean, United States is really diverse, but United States is so media driven too, and media tends to be kind of UC, because you don't, people that go on media and, they tend to be more on the UC side. They're comfortable with the limelight.
Sure.
So anyways, maladaptive overcontrol, basically where it starts to lead to things like chronic depression, like anorexia, like perfectionism disorder, OCPD. Mm-hmm. What's happening is that maladaptive overcontrol creates this low receptivity and openness for new experiences, for uncertainty, for disconfirming feedback from the environment. So they're very closed off. And that's where we get this idea of radical openness, kind of teaching the person how to be a little bit more open to new experiences, to feedback that they really don't want to hear, or, I mean, all of us probably have difficulty sometimes hearing feedback. I know I have.
Mm-hmm.
But I think for maladaptive OC people, it's really, really difficult. They do almost anything they can to avoid hearing disconfirming feedback, or, even novel experiences. The second way it manifests is just low flexibility. Tends to be very rigid, very rule governed behavioral patterns.
Mm-hmm.
And the third way it sort of manifests is pervasive inhibited emotional expression and low emotional awareness. So oftentimes, in terms of an OC person's social signaling, you'll see them have a very flat face, like almost all the time. Or it's kind of disingenuous, where the person will be smiling, but they'll be saying, yeah, my life's a living hell right now.
Mm-hmm.
Yeah. So it's kind of this disingenuous kind of social signaling. What happens with either the flat or disingenuous social signaling is it kind of pushes people away from them. Mm. And it makes it difficult for them to really be able to connect with other human beings, because that social signaling is impaired in some ways. So we teach them how to socially signal. And as a result of all these things, they tend to have low social connectedness and intimacy. And so they could have as therapists, oftentimes, I've told my clients, and you probably have too, hey, you got to connect with your support system. You got to have a support system. Well, a maladaptive OC person could have the best support system on the planet. They could have lots of people who love them and care about them, and they could still feel disconnected.
Sure.
They'll be aloof, and they just don't know how to really connect, and they have to kind of be taught how to do that. And so, as you can see, some of these things like depression, treatment-resistant anxiety, perfectionism, anorexia, and even, something that's very biotemporally anchored is autism spectrum.
Mm.
And so now RO-DBT is being used for kids and folks who are on the autism spectrum.
Super interesting.
Yeah.
Well, that's a wonderful overview. So do you want to talk a little bit about what treatment might look like? Or, when you start off the session saying you went to this, it was a 2-week training, correct? So fairly intense training.
Right.
And I'm guessing you're there all day long for 2 weeks. And what types of, can you share a few, either interventions or kind of ideas of what this looks like in practice? And here's my second question, which is somewhat unrelated, but you had said there were lots of things that you'd never heard of before. And I know you're a fairly seasoned, clinician, and I'm a fairly seasoned clinician. So when I go to places where I feel like my brain was blown, I really take notice, that's really valuable to me to be able to learn something that I hadn't thought of before.
Yeah, that's a great question. In terms of how treatment is offered, really the core is what are called the RO-DBT classes. And we don't even really like to call it group therapy, because from an OC perspective, even the word therapy, this was an interesting thing that I learned. The word therapy they don't even really like that word very much, because they sort of see that as being for people who are out of control,
right?
People who kind of need therapy,
right? Like you and me.
Yeah, exactly. Don't get Natasha and I together in a room, because who knows where it will go. I don't know.
Right.
We got some good work done in some of our board meetings, right?
I agree. We did do good work.
But we had some fun too.
Yes, we did.
So, But no, we call them RO-DBT classes because that is something an OC person is much more comfortable with. They're very comfortable with more kind of an educational kind of school setting. And that's kind of what we're really doing is we're teaching them skills.
In a group setting mostly then, not so much individually.
Right. Now there is, ideally the way it's practiced is they're attending the classes and they're getting RO-DBT individual therapy. However, there is research that they could keep their same therapist and keep doing kind of individual therapy as usual, and they would still get some benefit just by attending the classes. They're going to get a higher benefit if they also do RO-DBT individual therapy in conjunction with the classes. But in my practice, we have a lot of people who still, kind of keep their therapist, or their therapist kind of buys the RO-DBT book and, kind of does the best they can to weave in some of this stuff in their individual therapy. So the core really is the classes. That's kind of the main thing. And
so as part of this training, I'm guessing you became kind of certified or kind of was given a green light to be able to offer these classes in a way that the RO-DBT founders would feel comfortable with you offering.
Right. Yeah, it was nice because I got to be trained by the creator of RO-DBT, which, that doesn't happen every day for an evidence. It doesn't happen every day that, and an evidence-based practice, for depression and anxiety comes on board. And then, to get to be trained by the developer was really kind of a special thing. And he's really just an interesting, his name's Tom Lynch. And, the book is out there for therapists, or even, another funny thing that he said is that maladaptive people who have maladaptive OC, over control, they will probably have bought the book, have highlighted everything, read every single thing, and they'll be able to tell you where you're making a mistake and how you're treating the over control. So that was kind of a funny thing, because
interesting.
OC people, they do their homework.
They
research things, they do their homework, and they're very detail oriented. Another thing we kind of learned is, as therapists, we're trained to really, when we're listening to a client, we want to really give them the message that we're listening to them, that we're with them, that we're validating them, and that we're hearing them. And what he sort of said is some of us are having too much of a neutral, serious face with our clients. And with OC people, the way they're interpreting that, sort of, if the therapist is too neutral in their expression on their face, that they're automatically thinking that the therapist doesn't like them, or that they're judging them. And OC people they can drop out of therapy really easily.
Wow.
And, they can avoid, they don't even like coming into therapy, and they can drop out very, very quickly. So they really trained us to kind of watch our social signaling with, and so there's a lot, even in terms of setup of a therapy room, in terms of doing individual therapy, they've got, kind of some guidelines about how the chairs should be, along with the therapist's own kind of social signaling. So that was really interesting. I'd never heard much about that at all.
That is super interesting. Well, I guess I haven't been failing as bad as I thought then, at least with OC people, because I've always sucked at the blank face that you're supposed to have as therapist.
Well, here's the thing is, what they say is, most of us aren't even aware of it's hard to even be aware or mindful of our social signaling.
Yes. I agree. So, it is hard. You're so in tune with their story. Who knows what your jaw's doing, and your eyes and your eyebrows and your crinklies, and
Right. Absolutely. So, so they wanted us to tape our sessions, tape the classes to really be able to kind of see, how are we doing it? What's our social signaling like? And, being open to feedback, So, yeah, the classes are fun too, because some of our OC folks, they have not had fun in a very, very long time. And some of them are lonely as hell. And they, one of the parts that's really insidious to me is they're so stoic, they don't even tell anyone. And so they're at such a high risk for, for mental health issues that can go untreated, or it's just not what they need, and it's not what's effective for them. Another interesting thing, this just came up in class, is that, people are getting to kind of reverse the aging process. They're getting Botox. I don't know if you've had Botox.
I have not had Botox, but I'm not judgmental about it. Yeah,
I'm not anti-Botox, but the interesting thing is that it's freezing some of the nerves, and that may be causing some social signaling problems. And also, when we social signal, it's bidirectional. So it's sending out a message, but it's also affecting our nervous system too. And so if our face is kind of frozen in a certain way, yeah, it may make us look younger, but it actually may be contributing to some mental health issues and some social signaling issues for some people. So that was really interesting that was coming up.
That's super interesting. And I have heard concerns about, a face kind of Botox, kind of in a sense, creating this kind of facial neutrality, that then it is hard to kind of both ways, like you said, social cues and we do so much of our communication non-verbally, we don't even realize.
Oh, it's huge, And then the other thing is, and I think you might really like this, is RO-DBT talks a lot about, kind of our tribal ancestry, that all of us in our heritage, in our ancestry, human beings were in tribes, and tribes were, with non-human primates, if there's a chimpanzee or an orangutan, that gets disconnected from tribe, they can die within a few days.
Wow.
And so, in Maslow's hierarchy of needs, community is kind of in the middle there. But for ancient humans, there is no food, there is no shelter, there is no basic needs getting met without tribe. And so when people get disconnected from tribe, and that's kind of what we're sort of thinking is happening with OC people, is that they're getting disconnected from tribe. Kind of the goal of RO-DBT is that the therapist is almost like a tribal ambassador, saying, hey, welcome back to the tribe. You've worked extremely hard. You've made incredible self-sacrifices. And now it's time for you to be back in the tribe and to...
Wow, what a beautiful reframe.
Yeah.
Yeah. Well, I know that I have you pretty much at the time that we had discussed. Yeah. So what do we do with all this information? And I'm thinking about it from 3 different perspectives. Maybe you're listening to this and going, yikes, this really personally resonates, that I've tried treatments for depression. They haven't really been very effective. I almost kind of given up. My quality of life really stinks in a lot of different ways. I'm suffering, and I thought maybe there wasn't any hope. So that's one possible audience member. Another audience member might be a family member, right? Or a spouse of somebody that they're like, oh my goodness, maybe this is what's happening. I haven't known what the deal is. And maybe this is really resonating with a relationship I have that matters a lot to me. And then third, here at Mormon Mental Health, we're always trying to give tidbits of training indirectly to ecclesiastical leaders. which, granted, they have a lot on their plates to begin with, and not that I'm expecting them to be mental health professionals by any means. And yet they're oftentimes in the trenches and, in the forefront of having these people in their offices and not always, knowing, or I think any useful information for them would be really helpful. So given those three kind of populations, what's kind of maybe a short directive you'd like to give each one?
Yeah. So if somebody wants to kind of get more information on RO-DBT, the main website for it is radicallyopen.net. And one of the tabs on that website is find a therapist. And so you can kind of, wherever you're at in the world or the United States, you can kind of see who has been trained in RO-DBT and what their contact information is. So that would probably be the easiest and best thing, is for them to go to radicallyopen.net. That's the main website for RO-DBT. My website, and I'm happy to answer questions, and if there's interest, we can do a follow-up sometime. Or, people can email me or contact me if they have other questions. So my website is relationquest.com. And
perfect.
And there's a download where you can kind of find your coping style and see if you lean, how much quantitatively you lean UC or OC. And,
awesome.
And just because you have a high score doesn't mean means that you're maladaptive. Because I have a pretty high UC score, but hopefully I'm somewhat adaptive. I can be serious sometimes, right?
Right. Well, right. It just means that you lean strongly in that trait. It doesn't mean that the trait has become dysfunctional in your life.
Right. No, I'm, and you said a great thing, that both sides of the fence have strengths and then also some challenges that go along with it. So it's not that one is good and the other's bad, although sometimes one side or the other looks at the other side and thinks that side looks negative. I had a really good friend, coworker at work, and she's pretty OC, and she's like, why would anybody check off those UC traits? She saw those as very negative, which was really interesting. So,
right. Well, and that's another tribal mechanism. We otherize each other, right? So if you're not like me, then there must be something wrong with you.
Sure. Right.
So, and also how we get isolated.
Yeah.
Yeah. Okay, great. So if you're an individual, definitely check out Kevin's website, Relation Quest. Is that correct?
Yeah. Yep, all one word, relationquest.com.
And we'll make sure to link to that as well. And there's a fun little test you can take on the website that might let you know which way you're leaning. All right, what if you're a family member or ecclesiastical leader?
Yeah, they can go to the main website, or they can feel free to contact me if they want more information. I'm always happy to talk about these types of things. And, this is a relatively new treatment too. It is evidence-based. There's been a lot, over 25 years of research behind it, but it's only recently that people are getting trained in it. So
yeah, I had not heard about it until you mentioned it a few I think months ago now with me. And I was like, wait, what are you talking about? And you got to tell me about it. So yes.
Yeah. The book only came out it was probably about maybe 6-8 months ago.
Okay.
Yeah.
Okay. Good. All right. Well, I love being on the cutting edge of knowing what's going on. That's awesome. So what, if anything, did I not ask you about? What are your closing thoughts? What are you hoping people will get out of hopefully having listened to us for this hour?
Well, I hope that people are able to, especially those who have been struggling with depression or have had family members struggling with depression, where the regular treatments may not have been working so well. And when you're struggling with depression, you can easily lose hope and you can blame yourself. And so in RO-DBT, we talk about the importance of being open and kind of humble and recognizing that we don't know everything. And, I think RO-DBT maybe captured some things that maybe we didn't know about before, or didn't pay as much attention to, or didn't emphasize as much. And so there's some new hope here for targeting certain types of mental health challenges, and for relationships too. This is going to be really, really big, because now you can start to conceptualize it in terms of couples. How one couple might be, one person in the couple might be OC, the other one might be UC. Maybe they're both OC. What are the challenges and opportunities and strengths that, come with those types of things. So we're just learning new things all the time. And I'm just really excited about this new type of therapy. But, I have high reward sensitivity. So,
Right. Well, I can't thank you enough for your time and for sharing all this information so freely with us. It's wonderful. It's so nice to personally connect with you, but this has been really valuable. At least I love listening to this kind of stuff and learning. So you've definitely offered me a lot of information in that regard, and I'll be looking into this further. Please check out Kevin at his website, relationquest.com. He's also on the Mormon Mental Health Association's provider directory, which that's a resource that we, it's not necessarily tied to this podcast, but I was involved with that. Kevin was involved with building that resource for people within the LDS faith as a good place to find people who are culturally competent and practice evidence-based practices. So we both feel very strongly about our work in that regard, and that association's foundation. And tune in, next week or whenever I have another one of these interviews for more mental health tips and topics. Please feel free to leave comments, feedback. What do you like about what we're doing here at Mormon Mental Health? What would you give us maybe some constructive criticism on? And help us spread the word. So share with people that you feel like could benefit. And of course, always consider a donation, because we need your financial support to keep this podcast alive. And you can do that at mormonmentalhealth.org, which is where you'll find some very easy donation buttons, as well as the archive of all of the interviews that we've done. And we've covered a myriad of topics in regards to mental health, which is not maybe the sexiest topic, and yet is a topic that I believe is oftentimes, unfortunately, still taboo. It's something we all deal with in one way or another. And whether it's personally or through people we love, or in our ward communities where we want to support other people, it's so important to educate ourselves on good mental health practice and treatment. So thank you for joining us, and we'll see you next time. Thanks, Kevin.
Thanks, Natasha. Thanks, everyone.
Thanks for joining us today on Mormon Mental Health Podcast. If you enjoyed this episode, please help us and become a monthly subscriber at mormonmentalhealth.org. The goals of this podcast include education, advocacy, and the mental health and general well-being of Mormons and their families. We can't further this work without your support. Music for this episode was provided by the Lower Lights.
Over life's tempestuous sea, chart and compass came from thee. Jesus, Savior, pilot me, unknown ways before me roll, hiding rock and treacherous show, chart and compass came from thee. Jesus, Savior, pilot me.
As a mother still
ocean wild, wondrous sovereign of the sea. Jesus, Savior, pilot me. Boisterous wave, obey thy will, when thou sayest to them, be still. Wondrous sovereign of the sea, Jesus, Savior, pilot me. When at last I near the shore, and the fearful breakers roar, may I hear thee say to me, fear not, I will pilot thee. Twixt me and the peaceful rest, then while leaning on my breast, may I hear thee say to me, fear not, I